Guys, welcome back to the channel. So last class we have started with the clinical presentation of systemic lupus erythematous. We'll be continuing that topic only. Okay, let's start. Coming to differential diagnosis, drug-induced lupus syndrome. The facts about that are males are affected equally. There are no neurologic or renal components. Anti-native DNA antibodies are not present. तो डिफरेंशियल डायग्नोसिस में हम लोग ड्रग इंड्यूस ल्यूपस सिंड्रोम कंसिडर कर सकते हैं क्योंकि क्लिनिकल प्रेजेंटेशन ऑलमोस्ट सेम होता है लेकिन ये सारे डिफरेंस होते हैं. द क्लिनिकल पिक्चर इम्प्रूव्स इफ द सस्पिशियस ड्रग इज विथड्रॉन. Now second differential diagnosis is erythema multiforme and third is rheumatoid arthritis. इन दोनों का जो इनिशियल पिक्चर है वो सिमिलर होता है. Now coming to diagnostic workup. A physical examination and radiographic and lab studies are guided by ACR criteria. जो हम लोग क्राइटेरिया पढ़े थे लास्ट क्लास में उसी से डायग्नोसिस we will establish. Routine urine analysis and a 24-hour urine collection to assess for proteinuria and cellular cast indicative of glomerular damage. क्योंकि अपना systemic lupus erythematous में renal is affected. Glomerular filtrate. We have seen glomerulonephritis. Okay. A routine chest auscultation, echocardiogram, chest radiograph, pulmonary function test, particularly assessing for pleural effusion, restrictive lung disease and mitral valvular incompetence. Cytopenia from bone marrow suppression for bone marrow suppression. तो bone marrow suppression से cytopenia होगा उसके लिए हम लोग को रूटीन CBC भी लगेगा. The anti-native DNA antibody is specific for SLE and sometimes VDRL टेस्ट भी लगता है जो हम लोग सिफिलिस में करवाते हैं वो टेस्ट भी लगता है. Now coming to histopathology, oral mucosa में ulcerative lesion दिखेगा which is destruction secondary to interphase reaction. Now early skin lesion. Connective tissue edema is more pronounced. Extravasation of erythrocyte is mostly seen. Colloid bodies are seen and deposit of fibrin are more prominent. It occurs within the connective tissue causing thickening of collagen bundles. The deposits are strongly pus positive. Subcutaneous fat may also show involvement with mucoid degeneration and lymphocytic infiltrate. In virtually all cases of SLE, the granular deposit of immunoglobulin is seen. तो कनेक्टिव टिश्यू इडीमा ज़्यादा होता है, एक्सट्रावेसेशन ऑफ आरबीसी दिखेगा और जो डिपॉजिट्स होते हैं फिब्रिन के वो ज़्यादा होते हैं. नाउ कमिंग टू ट्रीटमेंट पार्ट. Mild form of SLE that runs an unprogressive course requires only supportive care. NSAIDs, antimalarial drugs like hydroxychloroquine 400 mg by mouth daily can be used to alleviate symptoms. Symptoms relieve करने के लिए we can give NSAIDs and antimalarial drugs. Now, most patients with SLE, particularly those with multi-organ involvement and or progressive disease, require systemic prednisone. Systemic corticosteroids लगते हैं. Mycophenolate and cyclophosphamide may be added to reduce the steroid requirement. Now coming to prognosis, it's gradually decline over time. 5% mortality at 5 years, 10% at 10 years and 22% at 20 years. Currently, 10 years survival rate is 80%. Those who survive the first 4 years generally have long-term survival, succumbing mostly from complication of long-term immunosuppressant therapy. एवास्कुलर नेक्रोसिस ऑफ द हिप एंड कैटरैक्ट मेनली सर्वाइव कर जाते हैं फर्स्ट 4 ईयर. जो सर्वाइव करते हैं उनका सर्वाइवल रेट ज़्यादा होता है लेकिन जो भी उनका डिटोरिएशन होता है वो ड्यू टू कॉम्प्लिकेशन ऑफ कॉर्टिकोस्टेरॉइड्स. The rapidly progressive form of SLE causes severe kidney damage, heart damage, or lung damage, leading to death, mostly from renal failure or pneumonia. That's all for today, and we have come to an end of SLE. We'll be starting new topic in the next class. Till then, like, share, subscribe, and comment. Bye.